Welcome, welcome, welcome. Welcome in everyone to Care Concierge with Carepatrol, where education is the heart of everything we do. I notice many returning visitors and guests today. Welcome. I also see some names that are new to me. If you're new to us, Carepatrol is a referral and placement agency. We advocate for aging adults for their care options and for their safety needs, and using information we gather from them we help them choose the providers that best meet their needs. And all of this we do at no charge. We're paid if those needs include moving to a senior community or using in-home caregivers. We refer those agencies which pay us if our clients end up utilizing their services. So we are free to you, to your friends and patients, just like this CEU is free. We are accredited by the Alabama Board of Nursing and also by the Alabama Board of Social Work. And each of those boards tell us that we have the right to offer this 1.0 contact hour to you today. I will say, for those of you who are with us live, excuse me, we are in the midst of renewing our certifications, which have expired this month, but we are renewing and hope to have those in place again soon. If you are on this website, on this site today, you know that in order to, or you may know that in order to receive credit, you must do our password protected evaluation, which stays open until 9 o'clock tonight for your use. Once those are completed, I will send a certificate to everyone, including nurses and social workers and anyone else who's on the call. If you're neither of those professions, welcome. Our link, I'll read for you now. Remember, we give the password at the end. And in that way, the Board of Social Work says that this is a live hour for social workers. The link is https colon // www.surveymonkey.com /lowercase r / all uppercase letters with numbers 5 T as in Tom W 2 9 R 3. That's today's link. I've posted it in the chat room. I'll post it again at the end along with the password. If you're watching this on YouTube, just listen for that link and password and take the evaluation, and we'll get you a recorded certificate in the email. Today, we're joined by returning presenter, Dr. Katlyn Roginsky, who is a fellow in the Department of Neurology at the University of Alabama Birmingham Medical School. She will be presenting to you a new idea for us, a new topic today, which is hydrocephalus. And we're most appreciative. Thank you, Dr. Roginsky. The floor is yours.
Absolutely. I'm so happy to be here. So just to get started, hydrocephalus is a deep topic. So we're going to spend most of our time talking about normal pressure hydrocephalus, which is probably what y'all would be seeing most commonly and what I see most commonly as a movement disorders fellow. And then so we'll go ahead and get started. So I have no disclosures for this talk. I work at UAB. The objectives are to identify the different types of hydrocephalus, understand the diagnosis and the clinical presentation of normal pressure hydrocephalus, and then understand the treatment of normal pressure hydrocephalus and be able to identify appropriate patients for treatment options. So as an introduction, generally hydrocephalus is just defined as a symptomatic accumulation of cerebrospinal fluid or CSF inside the cerebral ventricles. So when you look at the picture here, you can see the ventricular system exists kind of like in the deep part of the brain as well as down into the deep part of the brainstem as well. And then there's kind of like a line of it through the spinal cord, and then the CSF also bathes the spinal cord. When we're talking about hydrocephalus, we're only talking about the brain ventricles, so the cerebral parts of the ventricles. And you can see them on cross section or in axial views. This is just a depicted drawing, but you'll be able to see them on imaging as well. So hydrocephalus is when too much of that fluid accumulates for a variety of different reasons, and it causes enlargement of those fluid containing spaces or the ventricles. Just to kind of get a basis, CSF, to talk a little bit about CSF and how it's produced and absorbed. So the cerebrospinal fluid is chiefly produced in the choroid plexus. The choroid plexus is kind of a group of structures that are located in the lateral ventricles, which are kind of the biggest section of the ventricles seen on imaging and in the brain. It's also located in the third ventricle and then the fourth ventricle, which is this kind of triangle back here. So the choroid plexus exists within all of these, and in all of these ventricles, you'll get CSF production. And now, as the CSF kind of goes throughout the system, it'll eventually be reabsorbed, and it's reabsorbed in the arachnoid granulations, and those kind of exist really within like the venous system as well as the ventricular system. On average, CSF is produced at approximately 150 cc's an hour. So we're producing, well, a little bit less than that. But we're total, all in all, we're producing about 500 cc's, but only 150 cc's of that, or 150 milliliters, is existing in the system at any point in time. Throughout that kind of reabsorption process, it'll suck it in, produce more, suck it in, and produce more. But in the system itself, there's only 150 cc's at a time for 500 milliliters that was produced throughout the day on average. So the way that CSF flows, generally, if you think, even though the choroid plexus exists within all the ventricles, but if you think of it from the lateral ventricular system, so it's produced in the arachnoid granulations, whether that's in the lateral third or fourth ventricles. And then if it's starting in the lateral ventricles, it flows through what's known as the foramen of Monro to get into the third ventricle. And then it goes from the third ventricle through the cerebral aqueduct of Sylvius to get into the fourth ventricle. And then once it's in the fourth ventricle, it can take 3 separate pathways out of the fourth ventricle. So it can either go through the foramen of Luschka, which are 2 on the lateral sides of the fourth ventricle, or it can go through the foramen of Magendie, which is 1 midline kind of aperture that CSF can flow through. And then from there, it either flows out into the basal cisterns, which is kind of the area that surrounds the brain and the spinal cord, or it goes down through the spinal cord. And generally, the principle through which CSF flows is bulk flow. So as it gets produced and builds up, the pressure just pushes it down and out throughout the system. Okay, so that's kind of the nitty gritty nuts and bolts of the science part of it. And then moving forward a little bit, we're going to overview the basic types of hydrocephalus before we kind of take a deep dive into normal pressure hydrocephalus itself. So hydrocephalus does come in multiple different forms. So one form is congenital or developmental hydrocephalus. This is something that's typically present at birth, although it doesn't necessarily have to be. It can accumulate after birth. And often patients, like little kiddos that have hydrocephalus at birth or shortly thereafter, have hydrocephalus as part of some underlying genetic syndrome or as the result of some type of neural tube defect. So these things can also be related to prenatal hemorrhages. So a lot of times our premature babies are born with small hemorrhages in their ventricles. And when that happens, it blocks the ability of the CSF to be absorbed. It can also be seen in the setting of like a perinatal infection, same thing, kind of the infectious debris, the white blood cells, kind of pus, these types of things can build up and prevent the CSF from being reabsorbed. And all of that can lead to congenital or developmental hydrocephalus. The next type of hydrocephalus is what we call obstructive hydrocephalus, and this is the result of some type of blockage of CSF flow. So obstructive hydrocephalus can occur in any ventricle or along the ventricles along the system, and kind of which ventricles are enlarged gives you an idea of where that obstruction is. So if it's only the lateral ventricles, then that obstruction has to be somewhere between the lateral ventricles and the third ventricle. If it's all the ventricles, then you obviously know that obstruction is somewhere below the fourth ventricle before it gets out into the basal cisterns or down into the spinal cord. And that's what's causing all the ventricles to kind of back up and backflow and then get large. Most commonly, we see obstructive hydrocephalus related to tumors, but that doesn't have to always be the case. It's just the most common scenario, some type of tumor impeding the flow of the CSF. The next type of hydrocephalus is what we call communicating hydrocephalus. So this category includes normal pressure hydrocephalus, which is what we're going to talk about in more detail in a little bit. But generally what happens here is there's impaired reabsorption of the CSF, and that's what causes enlargement of the ventricles and CSF buildup. Most commonly, this is related to things like post-hemorrhagic or post-inflammatory changes, like we talked about in kiddos just a minute or two ago. But it also can be the result of normal pressure hydrocephalus, which we'll see in a few minutes is not quite understood the mechanism of that. But we know that it's a hydrocephalus, so the fluid kind of flows freely throughout the system. It's just that there's too much of it throughout the entirety of the system. And then the last type of hydrocephalus is known as hypersecretory hydrocephalus, which is just as it sounds, an overproduction of CSF. Typically, this is related to some type of underlying tumor, either a plexus papilloma or a plexus carcinoma. And basically what that does is it acts like an additional choroid plexus. And so it's producing more and more from the choroid plexus that is supposed to be there, but then also from the abnormal tumor. Similar to like a hormone secreting tumor in the pituitary system or something like that. It's just that it's producing more CSF. This is more common in kiddos because in adulthood, this would have been caught earlier on, the hydrocephalus and things like that. So more commonly, we're going to see this in kids. Okay, so that was kind of a broad overview of how CSF is produced and the different types of hydrocephalus. I know that was kind of fast. You could talk about these things for hours, but we just don't have that kind of time. So next, we're going to talk about normal pressure hydrocephalus in more detail. Again, this is something that I'm going to commonly see in the clinic. It's something that y'all would be more commonly seen as it's classically a disease of the aging. So just a general overview of normal pressure hydrocephalus. It is the most common form of hydrocephalus seen in the elderly, with the average age of onset being around 70 years old. Men and women are affected in equal numbers, so there's no predilection for gender. And the kind of characteristic features fall in what's known as the Hakim-Adams triad. So kind of three things at least lead you to think of this diagnosis. So people who have had progressively worsening gait impairment, whether that's balance, the actual degree of walking, using assistive devices, so on and so forth, some cognitive deficit, and then urinary urgency and or frank urinary incontinence. So in med school, they teach us that this is the triad of wet, wacky, and wobbly. So the incontinence, cognitive changes, and then their gait changes or progressive instability. The general epidemiology. So overall, normal pressure hydrocephalus is thought to account for roughly 6% of all cases of dementia that we see in our clinics, with an estimated incidence of 0.2 to 5.5 per 100,000 person years. As you can see, as you get older, the prevalence actually increases. So people under the age of 65, the prevalence is quite small at 0.003%. But in patients age 65 and older, the prevalence is estimated to be somewhere between 0.2 to 2.9%, which is a pretty significant degree of people, although that number sounds small. The pathophysiology, so it's not exactly clear what happens in normal pressure hydrocephalus? Why does this happen? Why does the CSF accumulate? Is it an overproduction problem? Is it an underclearage problem? It's not quite clear, but a lot of research has gone into this, and there's a lot of proposed mechanisms without a lot of data to back up any of these proposed mechanisms. So some of the things that they think may be happening is that there's some type of hyperdynamic flow in the cerebral aqueduct. So probably not all the flow is going down. Some of it is kind of regurgitating up and then back down and up and down. And so that kind of pushes more up into the system itself. They also think that maybe there's some reduced compliance of the subarachnoid space as we age. So the subarachnoid space is what contains the arachnoid granulations, which is where the CSF is reabsorbed. So as we age, we all know that our blood vessels become less compliant over time. That contributes to hypertension, these types of things. So they postulate that maybe the compliance within that system is reduced. And so it doesn't fill as much, so then it doesn't reabsorb as much, and then it kind of causes a backup in the system. They also think that maybe the pulse pressure, so kind of just like our pulse is in our arterial system, that the pulse of the CSF going through is increased, and it actually just increases the pressure of the system, and that causes the fluid to kind of be there. Again, they think maybe reduced reabsorption of the CSF in the venous system due to increased resistance, like I talked about earlier, or is this reabsorption occurring through abnormal mechanisms as we age, like transependymal flow, which is where kind of the resistance of the walls of the ventricles gets less, and then you see some of that fluid kind of extravasate out into the brain substance that sits right around the ventricles, that very deep white matter. Is there something there that happens, and now it's abnormal mechanisms, it's not reabsorbing as quickly as it would? These abnormal mechanisms are not as quick at reabsorbing. Is that what happens? Is the cerebral blood flow reduced in general? And so if you have kind of less cerebral blood flow, the CSF pressure has to compensate for that, because ultimately our intracranial pressure stays constant. That's the goal of the body, is to regulate our pressure in our brain. And so if we don't have enough blood coming in producing pressure, then we have to produce more CSF to keep that pressure in the brain up, keeps you upright and all these other types of things. So is that what's happening, is that there's just not enough blood flow getting to the brain? So in order to keep the pressure within the brain constant, the brain increases its production of spinal fluid. Are there some type of alterations in the expression of some of our cytokines and other types of things like TNF alpha and transforming growth factor beta, and these extra factors being around cause us to produce more? Is it that our vasoactive peptides like amyloid and tau, which we can see in Alzheimer's and other types of pathology, are these just accumulating? And does that accumulation cause some type of toxic process to go on, and then that leads to the CSF either being not absorbed as much because it's toxic to the arachnoid granulation, or it's overproduced because it's toxic to things that help to slow down production, kind of like a check balance? They're not really sure. And then the last kind of proposed mechanism is that there's loss of what's known as the Wind-Kessel effect in the skull base arteries. And it's basically saying that right at the base of the skull where the CSF drains out, there's increased resistance. And so it's not necessarily that there's more CSF produced or less reabsorbed, it's just a resistance problem. And that causes a backup in the flow, just like it would in a garden hose. All of this to say it's very complicated and we still don't know. When you break down that kind of Hakeem-Adams triad, so the three things that you're looking for in terms of causing all the issues or the symptoms that you're looking for kind of in clinic and clinic-based situation, the gait disorder part. So basically what causes the gait disorder? When we have increased intracranial pressure, so the ventricles are getting wider, there's more fluid buildup in the ventricles, what happens is we stretch and compress the fibers in the corticospinal tract. And the corticospinal tract is our motor control tract. So it's the fibers that come from the brain and go down into the spinal cord to control our motor pathways, and vice versa. So what happens is as the ventricles get bigger, those corticospinal fibers pass through the corona radiata, and that is in close approximation to the ventricles. And so when we stretch and pull those because the ventricles are taking up more space, then our gait and balance are impaired because our pathway receptor, like our pathway from the brain out, doesn't control our movement as well. Also, what we see as the ventricles stretch is that the tiny little blood vessels that are located in the brain are compressible very easily, just like our veins, our smaller veins and smaller arteries. The same thing applies in the brain. So when there's more pressure in the system, those tiny little arteries and veins get kind of pushed closed because they don't have enough resistance. And then that causes poor perfusion and then kind of these almost stroke-like changes in the brain in parts of the brain that we know control our gait and our balance, like the frontal regions and then the periventricular region, which is where the corona radiata lies in those corticospinal fibers. And then also you have to factor in that because this is a communicating hydrocephalus, the fluid accumulates all the way from the top down in all the ventricles. And so if you remember that initial picture, the third and fourth ventricles exist within the brainstem. And so as that takes up more space, the ventricles themselves, we're compressing important brainstem structures. And our brainstem is already a tiny real estate area to begin with. So any type of compression is going to lead to the same thing as those corticospinal fibers come down. We're pinching them or we're pinching the small blood vessels, causing stroke-like changes or stretching of the fibers that control our movement. When you talk about the dementia part of the triad. So basically, it's kind of a very similar phenomenon in that the lateral ventricles, so that kind of the meaty part of the ventricles up in the brain proper, they get bigger. And then the cortex pushes against the inner table of the skull because as the ventricles get wider, then it kind of causes an out push of the brain. And because the skull is hard, there's nowhere else for it to go, it just pushes up against it. And then when that kind of shears, that force of the brain pushing out against the skull and then movement kind of shears that force around, that leads to changes within the vascular supply. And then ultimately that change in the vascular supply causes these small stroke-like changes, and then that can lead to the dementia. It's generally what we see, and I'll talk about this a little bit later, is the pattern of dementia is what we call a subcortical dementia, meaning the cortex of the brain is preserved. It's just that the cortex pushes on this and then causes shearing forces, and then those deep, deep structures get affected by their blood supply. And then the last part of the triad is the bladder incontinence. This is kind of a very similar thing to the gait disorder, is that the fibers that run close to the ventricles in the corticospinal tract are stretched, and those fibers help us to control our bladder because our bladder is ultimately a muscle, just like the muscles in our arms, legs, these types of things. And so when those are stretched, then we don't have as good of a connection between the brain and the bladder, and that leads to loss of control of our bladder contraction. Also, as the disorder progresses and as the cognitive impairment becomes more and more severe, sometimes dementia is just precipitated by the cognitive impairment. Our signals are not quite as clear as they were when we weren't cognitively impaired, and sometimes that leads to episodes of incontinence just because of that. When you talk about the physical exam itself in these patients, so gait is a big one, and I'll kind of circle back to the picture that was on the gait pathology slide. But what you tend to see more commonly in these patients is the gait is it's characteristic. So, seeing someone walk in the clinic, seeing someone walk out of the grocery store, you can kind of pick out this gait pattern, just like you could pick out like a Parkinson's gait or something like that. What happens is the foot, so these patients, their feet are externally rotated, so their toes are kind of pointing outwards. They have poor foot clearance, meaning it's kind of almost like they shuffle along the ground. They don't pick their feet up as high as they should. They have difficulty turning on the body's long axis, so they have a hard time turning. And then they can also have things like gait initiation failure or freezing of gait, similar to our Parkinson's patients, in that it's hard to get that first step, but once they get going, things maybe get a little bit better. When they're crossing a doorway, it's hard to get through that threshold, but after the doorway, things get a little bit better. So when you look at this picture, you can kind of see what they're talking about here. So this is the middle person is our normal gait, how our normal footfalls are. Our feet are generally toes pointed forward. We have a pretty good distance from step to step. In NPH, the foot starts to turn out, and you can see the toes are pointing more in the lateral direction and the outward direction. We have less clearance from step to step, so the steps get kind of shorter and closer together. Which is what you see in Parkinson's disease without that kind of foot turning out base. And as you can see, this person, the normal pressure hydrocephalus cartoon here, generally they adopt a wider base stance too to help them keep their balance, as opposed to an average person stance or even a Parkinson's patient stance. They tend to have a very normal base, meaning they keep their feet kind of normally appropriated and not like wide to try and maintain their balance. Okay. And then what are the urinary issues looking like? So basically what happens is we have detrusor overactivity, and the detrusor muscle is that main bladder muscle. And so when it becomes overactive, it's squeezing when it should be relaxing, or it's squeezing all the time, so on and so forth. So patients will have a lot of increased frequency and also urgency. So like not only are they urinating more frequently because the bladder is contracting more, but when they have to go right now situation because of that continuous contraction or improper contraction. And then over time, this can lead to just frank incontinence, where the bladder contracts when it's not supposed to, and then you urinate. And then finally, the dementia part of it, like I said, this is what we call a subcortical dementia. So it lacks some of the things that we typically think of in like cortical based problems. So cortical based problems kind of have their own degree of things. Subcortical dementia is more what's kind of displayed here. So they have this psychomotor slowing where everything seems a little bit slower, takes them a little bit longer to process what's being said and then formulate an answer. Also to kind of get their body moving, that's also slow. They're going to have reduced attentional capabilities. Also, their executive functioning or kind of multitasking type thing, type picture is reduced. And then they also have visual spatial dysfunction, which like when you're doing testing, you're looking at things like, are they able to draw a clock? Are they able to copy a cube on like a MOCA and MMSE, these types of tests? And so this is more of that subcortical picture, whereas the cortical part of it is more like what we think of in Alzheimer's disease, where they have like frank amnesia, like they can't remember things, they forget how to do things, they forget how to do tasks. That doesn't commonly occur in a subcortical dementia. It's more that everything slows down and they're not as attuned to where they are in space because they have visual spatial deficits, but also attuned to everything going on because their attention is reduced. So it's a little bit different of a picture than you would classically see in dementia. This is an example. These all I took off YouTube just because this is recorded, and so this is an example of a patient with what's known as the magnetic gait. That's kind of how we describe it, because the feet turn out, they have decreased clearance. It almost looks like there's a magnet on the floor and a magnet on your foot, just pulling it back down. This is an example of that. So as you can see, his feet have decreased clearance, right? They're not coming up off the ground as much as you would expect. His toes are turned a little bit outward, and his stance is a little bit wider than you would expect. It looks almost like he's getting ready to do a squat, not just to stand still. And as you can see now, he has some of that freezing and start initiation hesitation where he kind of appears stuck in place. He's taking these small, like pittery-pattery steps that aren't getting him much of anywhere. This is pretty classic of an NPH gait, or what we're looking for in terms of an NPH gait. Now they're just showing that close up of the foot turned out and that decreased foot clearance. And this is one more example of an NPH gait. And I want you guys to try and keep this video in your mind, because we're going to kind of circle back to this patient in a few minutes. But this comes from from Albany University Medical Center up in New York. So this is a patient clearly needs assistance to walk, cannot walk unassisted, but she has kind of the same thing. So her toes are a little bit turned out. Her stance is a little bit better, which may be the fact that she's being assisted by two people. But you can see her feet are kind of shuffling along the floor. They don't quite come up as high as you would expect them to, or as your feet do when you're walking along the floor. And so that's kind of the classic pattern of what we call an NPH gait or a magnetic gait. Sometimes you'll hear us refer to that as gait apraxia. It's all kind of the same stuff. All right. So when you talk about diagnosis, this is a very kind of complicated flow chart from Continuum, which is kind of our up-to-date stuff for all of neurology. Continuum comes out once a quarter and it focuses on different things. So this came out of the most recent edition for disorders of CSF. So basically what this kind of complex figure shows is that it's really a 3-step kind of tiered process for the most part. So one is going to be these kind of first 2 boxes, history and physical exam. And so I guess these first 3 boxes really. So your history and physical exam, right? So asking about cognitive impairment, gait impairment, do they have other things that would kind of point you away from it? Things like hallucinations, rectal incontinence, dysphagia, or difficulty swallowing, slurred speech. These things are not really consistent with the diagnosis of NPH. Do they have any other issues going on, like language impairment, depression, things that could be clouding their cognitive picture? And are they on any medications that can affect their gait, cognition, or bladder control? And kind of narrowing it down from there. Then you want to do your exam. So looking for things like signs of dementia, whether that's a MoCA and MMSE or some other type of neurologic testing, whether it's formal neuropsychological assessments or just kind of the bedside stuff like MoCA, MMSE. Looking for anything that, again, would be inconsistent with the diagnosis, like are they bradykinetic, rigid, and tremor? That's more like Parkinson's, Parkinson's and NPH can kind of look very similar to some extent, but tremor is not going to be classic of NPH. Do they have other issues like extraocular movement abnormalities, like their eyes aren't doing what they're supposed to do, and that's leading to their gait impairment? Again, not typically a part of normal pressure hydrocephalus. Then you kind of, the next step, so one was like that history physical. The next step is their evaluation of baseline functioning. And for us, the most important part is going to be a gait assessment. So that gait assessment could be done in a couple of different manners. One would be a timed up and go test, which generally our physical therapy friends do for us. So timing how long it takes them to stand up and take a couple steps out of the chair. More frequently, what we're doing in clinic, if we're seeing these patients, is what's known as a 10-meter walk test. So we see how long it takes them to walk 10 meters, turn and walk back 10 meters. We usually have them do that 2 to 3 times and then average that to get a score or a time for them. You can also look for tests of balance if you think that there's some other issues going on. And then you kind of put those all together. And then from there, you move on to your third step. So the first is history and physical, then kind of your formal gait assessments and baseline functioning. And then the last is a CSF drainage test. So in patients that are suspected to have NPH, they have to undergo some type of temporary CSF drainage, whether that's just a high volume lumbar puncture at the bedside, which is what we do here in our LP clinics, but also is done sometimes on an inpatient basis. Some patients, if there's some issue getting lumbar puncture, or if the results from lumbar puncture are equivocal, can undergo a lumbar drainage procedure where they put in a more temporary drain. So it doesn't stay there forever, but it's more than just putting the needle in, pulling the fluid out, and then taking the needle out and closing back up. Stays there for a few days, and you kind of get to assess their gait, their cognition, these types of things over the course of a few days. And then if you have high suspicion for something else going on, you can send additional biomarkers. Like if you have high suspicion that maybe this is an Alzheimer's type pathology as opposed to a normal pressure hydrocephalus, then you can kind of go down that avenue as well. But really the kind of threefold things are history and physical, your objective assessment of gait, but also cognition, and then their response to a temporary lumbar or temporary CSF drainage procedure, whether that's a lumbar puncture or a temporary lumbar drain. This is a little bit doctory, I suppose, but I guess that's the benefit of having a doctor here. So some of the things, if you ever hear, physicians in clinic or neurosurgeons or other people talking about this, When you get imaging for patients, the vast majority of patients coming to see myself and my attendings in clinic, they already have imaging done and there's some suspicion based on imaging. There are a couple ways that we commonly measure to see if we think that this is normal pressure hydrocephalus, or, sometimes the ventricles can look really big, but it's just in the setting of global brain atrophy or shrinkage. So there are a couple things that we look at to see what's actually going on. So one, and I would say the most common, because all MRIs and CAT scans of the brain are going to contain this type of sequence, is the Evans index. So in the Evans index, you kind of want to look at it in this slice where you can see the lateral ventricles, and they almost look like they're two separate things, but they're not, in the front and back. And you want to take the width of that front part of the ventricles, which is this pink one, and compare it to the width of the widest part of the skull, which is kind of just about flush past the midline. And then you just kind of get that ratio of ventricle to skull. Somewhere from 0.2 to 0.25 is normal. It's clear ventriculomegaly if they're greater than 0.3. If they're not greater than 0.3, sometimes you're kind of in this middle nebulous range and you're not really sure what's going on. The other thing, and this is something that my attendings prefer to look at, but you don't always have these slices on imaging depending on where the patients have come from, is the callosal angle. So you're looking at this slice, you're looking at the lateral ventricles here as they kind of feed down into what's going to be the third ventricle, and you're looking at the angle between them. Normally this angle is somewhere between 100 to 120 degrees. If it's narrow, so it's between 50 to 80 degrees, that's an indication that this patient has normal pressure hydrocephalus. And then another thing, again, because you almost always have this sequence in an MRI or a CAT scan of the brain when patients are sent to you, is the anterior-posterior diameter of the lateral ventricles. I don't do this as often, but this does exist. So again, you're looking for the lateral ventricles, kind of like the chunkiest portion of it, measuring from anterior to posterior, which is front to back, the diameter. And then same thing, the widest part of the skull there in an anterior posterior diameter. And then you just get the average. That's considered ventriculomegaly if it's over 0.5. So if the ventricles are taking up about half or more than half of the space of the total skull volume. There are a lot of other radiologic findings, and some of these have become more prominent in more recent literature. So one of the big things that we never really looked at in the past was what's called DESH. So DESH stands for disproportionately enlarged subarachnoid spaces. So these little kind of spaces and crevices in the brain that exist, these we never really used to pay all too much attention to, but now they're becoming more important in the diagnosis of normal pressure hydrocephalus. And if patients have these enlarged kind of spaces where CSF sits and their ventricles are a little bit enlarged, it's all most commonly they're gonna meet criteria for a diagnosis of normal pressure hydrocephalus. All of these other things you can look at too, but I would say the most common things that are looked at now are these disproportionately enlarged spaces and the actual numbered things that I talked about in the last 3 slides. So treatment, these patients, the treatment is relatively simple, all things considered. There's only one available treatment for these patients, and it's some type of permanent CSF diversion. That's why the temporary CSF drainage is really important, because if patients respond to temporary CSF drainage, they're going to respond to permanent CSF drainage. If they don't respond to temporary CSF drainage procedures like high volume lumbar puncture or temporary lumbar drain, it's very unlikely that they'll respond to some type of permanent diversion, which is a shunt. Most commonly, we're seeing a ventriculoperitoneal shunt, so something that comes from the ventricles and then ends in the gut. But sometimes they do lumboperitoneal shunts as well, where it starts in the low back in the lumbar region and drains also into the gut, into the free space in the abdomen. But this is an invasive procedure, so you want to make sure that before you get there, that the patient has a reasonable chance of responding to this. When we look at patients and how to choose patients that probably are going to respond well to shunts are, again, some of these numbers like stroke volume and stuff, looking at B waves if they have some type of drain that allows you to look at B waves. But generally, what we're looking for in a clinic perspective is their response to the temporary CSF drainage, and if they lack white matter lesions on MRI. So like I said, some of those theories as to why these symptoms come about is that you get kind of compression of these these blood vessels, and then it causes small stroke-like changes. So if they have a lot of those small stroke-like changes, that damage is permanent, and they're unlikely to have a favorable outcome from any type of CSF drainage, because basically the damage is done. If they don't have a lot of those and they respond to your temporary drainage procedure, they're more likely to have a favorable outcome after surgery. Patients who don't have really good outcomes are patients that already have severe dementia, because as I'll talk about in a minute, we know now that dementia is not one of the symptoms that responds to drainage. It's really looking at the gait problems, and then sometimes the urinary issues also respond, dementia being the last to respond if it responds at all. If they have dementia as the presenting symptom, again, because that's unlikely to respond. Patients who are misdiagnosed or their symptom recognition is delayed, and so they've had longer time with disease. And then also if they have MRI abnormalities, like I just talked about, because that damage is typically permanent and it's already done. We can't take that back. So when you look at shunts, this is just a couple images of the shunts. So what happens is, and this is very cartoonized, but a catheter goes into the ventricle and it sits in there, and that catheter pulls fluid out of the ventricle. It's generally connected to a little cap that sits in the skull where the burr hole was created to put the ventricular catheter in. And then it almost always attaches to a programmable shunt valve. So the surgeons are able to kind of dial it up and drain more, or dial it down and drain less, depending on the patient and what they need. So it comes out, it attaches to that valve. And then it kind of comes down, it feeds all through the neck, all through the chest, and then usually it ends in the gut somewhere. And all of this tubing is under the skin. Nothing is external. Having something external is a risk for infection, so everything's internal. This is a CAT scan. So this is, most patients walking into the emergency department buy themselves a CAT scan of their head for various reasons, whether they're confused, they fell, so on and so forth. So patients that have a shunt, this is what you'll see. You can see that catheter kind of coming in and sitting in the ventricle there. And then this is what's called a shunt series, which you'll also commonly see in the emergency department or on the hospital floor for patients that have shunts or known shunt patients. And so what the shunt series is a series of x-rays looking at the continuity of the tubing. So this is a kiddo, which again, I don't see much of, but you can see the shunt catheter goes into the ventricles. That's the little plastic cap that sits in the burr hole to protect the integrity of the catheter, but also because you leave a hole in the skull when you drill through it. It's connected down to these programmable valves that the neurosurgeons can access externally. They don't have to, reopen it to change the settings. They're all accessible externally, typically by like magnets and things like that. So it's connected to those. And then you can see it kind of comes down here into the neck. Oops, sorry guys. And then it comes down through the neck and is down through kind of the chest cavity, and you can see it comes down into the abdominal cavity. And then on the spinal one, you can see that this is quite a lot of tubing for quite a little child, it appears. And so they kind of turned it around and it sits right in the abdominal cavity and just basically dumps the cerebrospinal fluid out into the abdominal cavity. So this is, if you remember that second patient that I showed you that was having two people helping her walk down the hallway. She couldn't stand up out of the wheelchair. She was taking those small steps that weren't really clearing the ground, was having a hard time. This is her after shunt placement. So as you can see, her kind of stride clearance and length is more back to typical, what we would kind of expect to see for most patients. It's not perfect. You would expect her to walk a little bit, probably more steady, and maybe her foot clearance to be a little bit better, but it's much better than where she started, requiring two people to even help her stand up and walk down the hallway. She's now doing it independently, and that's all just after shunt drainage. I just put these in here. The results of them don't really matter, but what does matter is kind of the timeline here. So we're looking at 2010, 2015, 2013, and 2013. These were the four biggest normal pressure hydrocephalus shunting trials that we had in the past. So we were basically at best working with 10-year-old data, 11-year-old data now, until recently last year, a new trial was conducted and published. in the New England Journal of Medicine, I believe is where it was published. And it was called the PENS trial. It is the first and only placebo-controlled double-blinded study looking at shunt efficacy in our normal pressure hydrocephalus patients. And what that found is that shunt surgery is effective for improving gait velocity and gait only. They had no effect on patients' cognitive status or their urinary incontinence at 3 months in our patients with idiopathic normal pressure hydrocephalus that were appropriately selected for shunt surgery. This study is continuing on. They'll have a 12-month arm that should be published sometime this year, hopefully. But this is the only kind of rigorous study looking at shunts in our normal pressure hydrocephalus patients. It took them until 2025 to really show what we already knew as practicing clinicians, that shunts help our patients with their walking and their balance, but really not much else. So the prognosis for patients, like I've talked about a couple of times, gait has the highest probability and earliest timing of benefit, with their cognitive and urinary outcomes being much more variable. Some people will notice some improvement, but generally we never quote that these things, like their cognition and their urinary outcomes, are going to get better. Things that favor a good cognitive recovery, so patients that do report that their cognition improves after shunt, is if they had mild cognitive impairment with shorter duration of cognitive symptoms before they had shunt placement. If they have this kind of clear subcortical pattern on testing that I talked about, so it's more that executive dysfunction attentional stuff, as opposed to an amnestic dementia type phenotype, which is more indicative of some other process going on with the normal pressure hydrocephalus. And then again, if they have no concordance with Alzheimer's pathology on testing. Because normal pressure hydrocephalus doesn't have to occur in isolation. You can see NPH in the setting of Parkinson's or Alzheimer's or a lot of other things. It doesn't just have to be its own issue. It can co-occur. The big things to talk about is, any surgical procedure is not 100% fail-proof, right? There are complications for patients. So if patients go untreated, they opt not to pursue shunt, or they're deemed not an appropriate shunt candidate. What happens is they tend to have progressive gait impairment that leads to falls. They then lose their independence because they need assistive devices to walk or assistance from other people to walk. They get complications related to immobility like pressure ulcers, deconditioning, muscle atrophy, these types of things. They can get incontinence-associated dermatitis from having kind of that wetness along their skin folds all the time. They're more prone to urinary tract infections, and then their dementia also progresses. On the flip side, when you treat patients with shunts, it's not completely risk-free. The most common things that you're going to see are related to over-shunting. So patients can get subdural bleeds or fluid collections because you're draining too much of the fluid out of their ventricles. They can also get things like orthostatic headaches. So when they stand up and the pressure in your systems overall drops until your system equilibrates, they can get headaches. They can have nausea. They can have these small, tiny little ventricles from over-shunting. Infection is also a big thing. Anytime we cut into the skin, there's a risk of infection. So these shunts can get infected and have to come out. And then, of course, there's always the risk that the shunt itself malfunctions or becomes obstructed for some reason. And then that leads to just reaccumulation of the symptoms that they were already having from too much fluid in the brain. These are just a couple pictures. So from over shunting, on this picture on the left, you can see that there's a little bit of a fluid accumulation here. And you can also see this theoretically sits in the ventricle, but they've drained it so much that the ventricles have become split ventricles, and now you can no longer see where the ventricles sit. And then this is on the left, picture A here shows a little bit of over drainage. So you can see they've had a bleed kind of right along here on the outer surface of the brain. And that's because as we pull fluid in the brain kind of shrinks back to what is more of its normal size, we have blood vessels, these very flimsy veins that kind of run from our meninges down into the brain. And as the brain kind of contracts, it pulls on those, shears them, and then you get this blood accumulation or a subdural hematoma. All right, just to kind of go through, this is not something that we currently offer here at UAB, but it is offered at a lot of academic centers throughout the nation. So like Duke, I think was the closest one that I saw advertised on the internet for a multidisciplinary clinic approach to the management of idiopathic normal pressure hydrocephalus. But there's a lot of other centers like Barrow Neurologic Institute, that's in Arizona, that offer this multidisciplinary clinic. And so I just thought this was interesting. The team members for most of these multidisciplinary clinics include the surgeons, a neurologist, preferably a movement trained neurologist, but that's not always available. We are a little bit few and far between in the grand scheme of things. A neuro rehab specialist, so someone from PM&R, a neuropsychologist to do the cognitive assessment battery, our therapist, PT, OT, and speech therapy, a radiologist who reads any imaging, and then a nurse coordinator that can help push these patients along the pathway and make sure that there's no breaks in kind of their continuity of care. The evaluation for these patients, so in this is typically like a 1-day clinic session is what most of these places kind of have come up with. They come in and they have standardized evaluations. So each patient gets a timed up and go test or a 10-meter walk test. Each patient gets the same neuropsychological testing, whether it's a MOCA and MMSE, but it kind of keeps it consistent. They also get immediate access to a CSF drainage procedure that's typically a lumbar puncture. So, they'll have their initial assessments, they'll get their lumbar puncture, and then they'll have their post-LP assessments, which are generally just either your timed up and go or your 10-meter walk test, depending on what you did pre-lumbar puncture, and then also some post-operative care. So making sure that they're kind of followed along the trajectory of their diagnosis and treatment plan. The benefits is that it helps to improve diagnostic accuracy for patients. It also improves patient selection. So it's important to select patients that are going to respond well to shunts. And it helps to select those patients when you're kind of putting them all through the same rigorous type testing. It streamlines the process for patients, which is really great, and ensures that they have appropriate follow-up care with their neurologist, neurosurgeon, whoever needs to be involved in care. And then having that neuro rehab specialist, like someone from PM&R, is really helpful because these patients have been compensating for their balance and cognitive impairment and stuff for quite a while, most often before they're diagnosed and they have a shunt placed. So having someone that's getting them through the next step. So after their surgery, the next step is rehab. So having someone that can kind of push them along that path as well is pretty helpful. And this was just a study that was published in the Green Journal of Neurology, I believe, looking at like data from a clinic. And it did show that these patients, like their diagnosis was more accurate and their response to shunt was also better when they were in one of these multidisciplinary care clinics. So it's just something interesting to consider. But again, not something we offer at UAB currently. And those were my sources. Sorry that this one's a little bit more boring and less exciting than Parkinson's, but still important.
I think we had one question that you answered in the presentation. Let's see, maybe we have another coming up. Mariah Torrance says, thank you. And I'd say thank you, Dr. Roginsky. You were right. That was a lot of information to absorb, but I appreciate you doing it so concisely and quickly.
Of course.
And I hope that I'm wondering if that prompted any questions. While we're waiting, I will read again for you the link to the evaluation for this course. It is https://surveymonkey.com/lowercase r/ all uppercase letters with numbers 5 T as in Tom W 2 9 R 3, and our password today is hydrocephalus, and I will spell that for you so you don't fail a spelling test and not get into the presentation. Hydrocephalus is spelled as the password with a capital HYDROCEPHALUS. Hydrocephalus is the password for today's course. Thank you all for being here. I'm not seeing any more questions. I've posted the password and link into the chat room for you. Does anyone have any other questions while we have Dr. Roginsky with us on the line? I know I've seen several folks say could you put the link back in the chat? Yes, I will. The link is right here in the chat. Password is hydrocephalus. If I can spell it. There we go. I think that must be it for today, Dr. Roginsky. Thank you again. I hope to have you back later this year on another topic of your choosing. And it was very informative, as so many people are saying in the comments. Do you have any closing remarks?
No, I'm always happy to be here, and thanks so much for your attention over lunch, guys.
Thank you, Dr. Roginsky, and thank you all for being here. Join us in 2 weeks on the 21st at noon when Wayne Rogers with the Jefferson County Sheriff's Department will continue our series on crisis intervention. So we hope to see you in 2 weeks. We're glad to see you today and hope that the next 2 weeks leaves you healthy, happy, and fulfilled. Thank you all for being here. Thank you again, Dr. Roginsky. Y'all have a great day. The password, Ms. Pittman, is one capital letter with an H. The other letters are not capitalized. It should be working. I'll hang on one more minute just to make sure that you can get in, and I'm not seeing any issues. So I'm going to say goodbye to you all and thank you, as always, for all that you do.